About the aspect of the gynecological surgery. First of all, we know that female pelvic anatomy and pelvic organ related to the other organ in the pelvis. And this slide reveals the ligament that attach the uterus to the pelvic organ and support the uterus and prevent prolapse. First of all, common use surgical termination of pregnancy, surgical abortion. As mentioned previously in lecture of abortion, we have surgical abortion or induced abortion. First of all, manual vacuum aspiration. This is to induce the termination of pregnancy below 6 weeks. This instrument used for termination of pregnancy if failure of vacuum or medical termination, and the complication and issues mentioned previously in rupture of the abortion. This comparison between and select the method of abortion according to the complication. As we know, incomplete abortion, risk of death, infection of unsafe fertility, traumatic injury, and psychological problem. Another aspect of gynecological surgery, hysterectomy. It is the common in the postmenopausal and abnormal uterine bleeding. Hysterectomy, surgical removal of the uterus, is performed at the rate higher than that of any major operation. The cervix, ovary, and/or ovarian tube may also removed. Surgical approach, either abdominal or vaginal, open or abdominal surgery. Is an incision which is used usually transverse lower abdomen or vertical midline incision, either like cesarean section or midline according to the pathology associated with uterus. If uterus have multiple uterine fibrin and big size, need some time or adhesion, need upper midline. Minimally invasive surgery. This is keyhole approach requires only small incision on the abdomen, and laparoscopic assisted vaginal hysterectomy was done. Conventional or hysterectomy by robotic assisted surgery. Type of hysterectomy: subtotal hysterectomy, partial, total hysterectomy, pan-hysterectomy, radical hysterectomy, and ultra-radical hysterectomy. This type of hysterectomy depends on the indication of hysterectomy. So, evidence demonstrates that in general, vaginal hysterectomy is associated with better outcome and fewer complications than laparoscopic or abdominal hysterectomy. And this is preferred usually for prolapsed uterus. Things that make vaginal hysterectomy easier: prior vaginal delivery, no adnexial pathology, ovarian cyst, mass, anything, uterus less than 250 grams. Things that make vaginal hysterectomy more difficult: if nulliparous, prior cesarean section, adnexial pathologies, severe pelvic adhesion, morbid obesity. Advantage of laparoscopic technique: total laparoscopic hysterectomies and vaginal hysterectomies have been found to result in increased blood loss, shorter hospital stay, and recover as early as possible, fewer abdominal wall infection. However, laparoscopic approach involves a long operating time, require a certain level of surgical expertise. Vaginal approach has a high risk of pelvic hematoma with an incidence of around 30%. Indication of hysterectomy: either malignant disease of the cervix, uterus, ovary, fallopian tube, non-malignant, chronic advanced tubal infection, ovary complication, extensive endometriosis, obstetrical, catastrophic such as uncontrollable postpartum hemorrhage, uterine rupture, uncontrolled uterine sepsis developing from septic abortion. Number 4, continuous severe bleeding after several menstrual period, and 2, non-diagnostic dilatation and curettage was done, or uterine fibroid, uterine prolapse. Pre-operative patient counseling should be prepared for hysterectomy as the name of proposed procedure, of course, and of treatment. The purpose procedure intended benefits, serious and frequent occurring risks. Serious risks include overall risk of serious complication as abdominal hysterectomy and damage to the bladder, long-term disturbance to the bowel, bladder dysfunction, and damage to the bowel. Hemorrhage requiring blood transfusion, return to theater because of bleeding, maybe wound healing, or any other complication of any surgery. Pelvic abscess, venous thrombosis, risk of death within 6 weeks. Remote complication that vaginal discharge infection or vaginal vault prolapse after hysterectomy and global gag, menopausal symptom, sadness, irritability in younger female. The main cause of death are pulmonary embolism and cardiac disease. Frequent risk. Frequent risk include this risk factor for wound infection, pain, bruising, delay wound healing, numbness, tightening, and the frequency of micturition, ovarian failure, any extra procedure which may become necessary during the procedure, such as blood transfusion, repair of bladder, bowel injury, and repair of rectomy for unsuspected disease. But the procedure is likely to involve the benefits and risk for any available alternative treatment, including no treatment. Anesthesia complication may lead to another complication. Endoscopic surgery in gynae, laparoscopy, and hysteroscopy. Commonest energy source used in laparoscopic surgery: electrical, laser, ultrasound, and ligand. Sure. Basic indication for operative laparoscopic, either basic or intermediate. Basic tuber sterilization, common use for complete family and need tubal ligation. This is better and less stay in the hospital, less blood, less wound infection. Biopsy, coagulation, mild endometriosis, aspiration of small ovarian cysts. Intermediate, cases of mild to moderate adhesion, coagulation of moderate endometriosis, aspiration of small ovarian cysts, uterine suspicion, salpingectomy for ectopic, removal of weak clip of reverse of sterilization, and other indication. Extensive cuff salpingectomy for ectopic, classes of extensive adhesion like intermediate, and in addition to myomectomy, tubal anastomosis, hysterectomy, pelvic or aortic lymph adenectomy, and suspicion of reaction for collapse or stress incontinence. Advantage: it is minimally invasive and surgery, minimal abdominal wall scar, minimal stay in the hospital, no drying or of tissue, minimal tissue trauma, magnification allows tissue to be identified and accurate treatment should be applied, reduce oozing due to positive pressure, less post-operative adhesion. Efficiency is cost effectiveness and minimal post-operative discomfort, restriction, early return to work, shorter hospital stay. Documentation in percent later on give a chance for self-analysis and can be imparted on education. Disadvantage of laparoscopy: less experience, specific expensive instrumental required, trained nursing and other staff in the theater, and surgery time prolonged. There are risks of electrosurgery or laser that must be avoided. Another complication, aesthetic complication, as any surgical procedure was done, inadequate muscle relaxation, mask hyperventilation, air embolism. Another also related to anesthesia complication on pneumoperitoneum, gas-specific effect, pressure effect of effect number one on respiratory stenosis and expensive pressure on intravenous circulation. Hypercapnia reduce CO2 to the blood circulation. Effect of renal system increase intra-abdominal pressure and reduce RBF, reduce glomerular filtration rate, and ADH activity, reduce urine output. Pneumothorax due to true diaphragmatic hernia without any apparent cause, subcutaneous or superficial emphysema due to CO2, vein infiltration, the loss of areolar tissue of the body, subcutaneous and subfacial emphysema is rapidly resolved within 2 to 4 hours after operation. Complication of port entry, either hemorrhage due to injury to any blood supply, superficial or deep, injury to the intestine, to ureter infection, port hernia, or maybe complication related to diathermy, to perform surgery, to patient-related complication of ascites, organomegaly, organic damage, clotting problem. Post-operative complication increase in sometime in those patients with risk factor. Contraindication, either absolute or relative. Absolute, general peritonitis, intestinal obstruction, clotting abnormality, liver cirrhosis, failure of tolerate, general anesthesia, uncontrolled shock. Relative, multiple abdominal adhesion, organomegaly, abdominal aortic aneurysm. Another type of surgical is hysteroscope. نظر بطانة الرحم. Indication of hysteroscope, abnormal uterine bleeding, habitual abortion, pathology of uterine, suspicion by other method, follow-up of uterine surgery, complication of the curettage, trophoblastic disease, uterus tubal implant, IVF, secondary amenorrhea, and with negative estrogen, progesterone test, pelvic pain, cancer. Surgical indication, adhesion, septum, polyps, submucosa, myoma, dysfunctional uterine bleeding, tubal catheterization, temporarily, intra-tubal device of homeo and definitive silicone liquid, sterilization, removal of foreign body, such as intrauterine device. This is the instrument that used by the hysteroscopy. This is the camera on this insertion of the hysteroscopy to the vaginal and to the cervical and uterus. Complication of hysteroscopy, either due to gaseous distension, nitrous oxide, pulmonary embolism, bradycardia, and collapse, or carbon dioxide, pain in the area of the scapular bone due to stimulation of the phrenic nerve, and that disappears spontaneously after some minutes. Hypercapnia, acidosis, arrhythmia, cardiac arrest, and complications that occur due to gas embolism. Secondary to the distension of the liquid, either overloading of the fluid that used, or anaphylaxis and encephalopathy, hyperglycemia, hemodilution, or air embolism. Another complication, infection, traumatic hemorrhage due to intra or post or after hysteroscopy. Thank you for listening.